All right, welcome back. So now let's continue the cases. So if we look at this patient's case, this is a spot diagnosis. We're looking at a clear-cut case of a right-sided large pneumothorax. So this is a right-sided large pneumothorax. As quick revision, there's air, but there's no bronchovascular markings. They are absent. Look at the left side compared to the right. Again, no bronchovascular markings, just composed of air, and all this air is compressing the right lung. So you can see the visceral edge of the lung. It is being compressed towards the other side. But remember, this is a case of large, right, this is a right-sided large pneumothorax, but there's not so much shifting of the mediastinum towards somewhere else. So it is not tension pneumothorax. And remember, you don't need imaging to diagnose tension pneumothorax. You can do it clinically. So this is a case of simple pneumothorax that's right-sided and large, all right? Look at this case, for example. Now, if we look at this case, this is a very spot diagnosis for a very specific disease. So we can see multiple lesions here, multiple cavitary lesions. So lesions that are of soft tissue density, but there's an area of lucency within the center, suggesting they have been ruptured. So we have multiple cavitary lesions, specifically on the right lower lobe, the right middle lobe, as well as the left lower lobe. This huge mass over here extending towards the heart, essentially. So if you have, let's say, multiple cavitary lesions in a patient with, let's say, shortness of breath, and in a patient with eosinophilia, for example, in a patient with hemoptysis, and a patient with hematuria, then these cavitary lesions, with this patient's clinical presentation, you'll think of Wegener granulomatosis. All right, so Wegener granulomatosis is a multi-systemic disorder. It's a multi-systemic disorder associated with vasculitis. Is another video for another time. So again, chest X-ray. It helps when you know the patient's history and you know what you're looking for. Chest X-ray is here, chest imaging in general, they're here to confirm your diagnosis, not make it for you. So this is a case of Wegener granulomatosis due to multiple cavitary lesions. Now look at this one. If I told you that we have a patient's history, again, the patient's history is important, but you can tell from spot diagnosis this patient has cardiomegaly. But if I told you from the patient's history, this patient has pleuritic chest pain that is only relieved when he leans forward. This patient has also cough. This patient, dry cough, let's say. This patient also has dyspnea. This patient, when you did auscultation, you heard a high-pitched scratching sound. And this patient, before 2 weeks, he had an upper respiratory tract infection. So what is your most likely diagnosis with this patient's case? You'll say pericarditis. But this is pericarditis, which eventually is complicated with pericardial effusion, and of course with accumulation of fluid surrounding the heart. You will notice it takes on the appearance of a globular shaped or water bottle shaped. Is this confirmatory? Not really. You can do echocardiogram to confirm the case, but again, X-ray can help a lot. All right, it can help a lot in localizing the diagnosis. All right, so this is a case of pericardial effusion due to pericarditis. All right, so that's pretty much it for this case. Look at case number 25. Case number 25 shows a spot diagnosis of cardiomegaly. So if we do the cardiothoracic ratio, again, it'd be more than 50%. And of course, you can tell, in addition, some things that help you as well is that this patient has a cardiac issue. He has practically a one-lead pacemaker, in which we have this one lead coming all the way towards the left ventricle, all right? And along with this one-lead pacemaker, he had a history of cardiac surgery. So this history of cardiac surgery, thanks to the scars, as you can see here, these are not scars, but these are sutures. You can see the presence of sutures right in the middle. They call these sternotomy scars or sternotomy sutures, which suggests that this patient had a cardiac surgery for a very severe case of maybe MI or heart failure. Who knows? All right, but these here suggest that this patient has sternotomy scars, these sutures, sternotomy procedure, and he had a pacemaker inserted with one lead all the way towards the left ventricle, alongside the fact that this patient has cardiomegaly. And also sometimes you notice widening of the mediastinum. So you can see the mediastinum here, it's slightly widened, especially involving the descending aorta or within the aortic knob. So there's widening of the mediastinum, and that can mean a whole bunch of things. Again, maybe if I told you that a patient has severe chest pain radiating to the back, aortic dissection, for example, but oftentimes when you have mediastinum widening that is focal, or let's say diffuse, it might suggest bleeding, it might suggest fluid overload, whatever the case might be. But these are all the overall findings in this chest x-ray. Now, if we look at case number 26, here we have a case again of cardiomegaly. So you can see that overall the heart is enlarged. If you do the cardiothoracic ratio, the vertical diameter of the heart over the vertical diameter of the lung, the lung parenchyma, you'll notice that there's cardiomegaly. And again, cardiomegaly can mean so much things. There's a whole bunch of differential diagnoses. It depends on the patient's history. Look at this one. Now we have a case of another cardiac case. Now, if you notice here, this patient, again, this patient has a cardiac problem. He did sternotomy, he has sternotomy scars or, sutures from a sternotomy procedure. But if you notice, he also has a valve replacement. Now, valve locations, it depends on a specific criteria. So if you imagine if I did a karate shop, so for example, if I did a karate shop here, if you look at my mouse, let's say that I did a line here, all right? I did an oblique line. There's an oblique line, and whatever line or whatever crosses the line from above, we will assume that this patient has a tricuspid valve replacement or a pulmonary valve replacement. So you can imagine an imaginary line right in the middle of the heart. Whichever crosses the line from above, we'll say this is pulmonary or tricuspid valve replacement. But if we have this vertical line and we see there is calcified valves, remember, not calcified valves, we have metallic valves. And remember, metal on X-ray, they appear super dense. So if we have an imaginary line here, all right, if we have an imaginary line here, and these are valve replacements that are below this line, then we will assume that this patient might have a mitral valve replacement, or more than likely to be an aortic valve replacement. So the location is important. You can imagine this imaginary line above and below. The ones below, like you see in this picture, could be more than likely aortic valve or a mitral valve, if you don't remember. Again, patient's history helps a lot. From the patient's history, you will be expected to know that this patient had a valvular heart disease and he did valvular replacement surgery. All right, so this could be more than likely aortic valve replacement or mitral valve, which is very nearby. So that's pretty much it. Again, incidental findings. Look at case number 28. This is very obvious. The spot diagnosis that this patient has dextrocardia. So you can see in this patient's X-ray right here. And dextrocardia, that can mean a whole lot of things. Remember, there's another incidental finding along with dextrocardia. You can also see the stomach. It's the stomach containing of gas bubble. It's now on the right side and not on the left side. So, and that means the liver and the stomach, they switch sides. The heart, it switch sides. So now you're thinking situs inversus. Maybe this patient has Cartigner syndrome, especially if we gave you a patient history of infertility, recurrent infections, and a whole bunch of things, all right? So this is a case of situs inversus, by the way. Now, let's look at case number 29. This is a very clear-cut case of bronchiectasis. Now, bronchiectasis is very made clear on a chest CT, especially high-resolution chest CT. But if it's an advanced stage, you can also diagnose bronchiectasis on a chest X-ray. Remember, what is meant by bronchiectasis? Bronchiectasis is defined as dilation of the bronchial airways. So the bronchioles that are typically invisible, they can be very much dilated and permanent dilation. And if there's permanent dilation with visibility of the interstitial markings surrounding it. So there's many pulmonary blood vessels that are visible surrounding it. And you can notice multiple dilated bronchial airways. So 1, 2, 3, 4, 5, 6, 7, 8, taking on the appearance of a honeycomb appearance. You add all of this together, you think of bronchiectasis, which is often accompanied with interstitial fibrosis or interstitial lung disease. Oftentimes, usually, all right? So, a case of bronchiectasis with a honeycomb appearance, so bronchiectasis with pulmonary fibrosis or interstitial pulmonary fibrosis because of the honeycomb appearance, all right? And because of the area of opacification or the visible pulmonary markings surrounding the dilated bronchial airways. But everything else looks normal. Also, you can notice the trachea as well. It's also deviated towards this region as well, again suggesting pulmonary fibrosis. Now, let's look at case number 30. Case number 30 suggests to you the case of bamboo spine. So again, if you have multiple vertebral bodies with very little intervertebral space, you can think of it as a case of bamboo spine, and bamboo spine oftentimes occurs due to ankylosing spondylitis, for example. So this is case number 30, an orthopedic case. Well, this case doesn't have much of an issue. And if we look at case number 31, again, it showcases the bamboo spine that we're looking at here, where there's destruction of the intervertebral spaces. All right, so that's pretty much it for the bamboo spine. Oftentimes, people with ankylosing spondylitis, they are complaining of sarcoileitis. So sarcoiliac joint, there's inflammation in the area and it's bilateral. All right. Now, if we look at case number 31, this is a spot diagnosis. This is known as right ossified hemisthorax. We will not say anything. We will say for now, right ossified hemisthorax. Then afterwards, we start to think of the differential diagnosis. So whenever we have a right ossified hemothorax, something occupying an entire lung field, this could be blood and this could be fluid, and this could also be lung collapse. So how do I differentiate all of these conditions that can cause an ossified hemothorax? By shifting of the mediastinum. So if I have a right ossified hemothorax with shifting of the mediastinum contralaterally, you start to think of massive pleural effusion. All right, this is more than likely to be a massive pleural effusion. Another differential diagnosis, it could also be a case of pneumonia, for example. But atelectasis oftentimes cause ipsilateral shifting of the mediastinum. Pneumonectomy, if someone removed their lung, there will be ipsilateral shifting of the mediastinum. So oftentimes, if someone has pneumonia, if someone has a large pleural effusion, or even if someone has a large hemothorax, blood within the lung field, all of these can cause shifting of the mediastinum contralaterally. So if you have a right ossified hemothorax with shifting of the mediastinum contralaterally, you have your own differential diagnosis. Maybe pleural effusion, maybe pneumonia, maybe hemothorax, not hemothorax. And oftentimes it's the same thing. Hemothorax is the same as pleural effusion, but it's composed of blood instead of fluid. All right. But if there is ipsilateral shifting, you think of atelectasis, you think of pneumonectomy. And oftentimes pneumonectomy is visible if there is an absent rib. All right. So this is a case of right-sided ossified hemothorax due to massive pleural effusion. Now for case number 32, oftentimes this is a PH chest X-ray, which is showcasing again a case of pulmonary alveolar edema on a bat wing-like appearance. Again, you need the patient's history, but this is more than likely to be a pulmonary alveolar edema, so associated with congestive heart failure. All right. Now let's look at the next case. Now the next case is very interesting. It's the same thing. Now what is the issue in this picture? The issue in this picture is two things. Number one, you could notice that the exposure to this X-ray is not normal, because you can see that the spine, it is visible. It is way too visible. We suggest over penetration. We suggest that we have darkened the imaging. If we darken the imaging, we will find the spine very visible. It should be visible, but not to this amount. That is the issue with this imaging. The second issue with this imaging is the abnormality at hand. The abnormality is, we can see here, there is a large left-sided opaque hemothorax, alright? And there's a large left-sided opaque hemothorax, which also shows air bronchogram, which further supports pneumonia. This is also another differential diagnosis between pleural effusion and pneumonia. This is a good one as well, if you have the presence of air bronchogram as well. So if you have a case of air bronchogram with shifting of the mediastinum contralateral on a left-sided opaque hemothorax, you think of pneumonia as well. But again, you add that with the overexposure, over the over-penetration, because of visibility of the lumbar spine way too much, you can't trust the finding as much as you want to, alright? You'd order another chest X-ray. Look at this one, spot diagnosis. Again, you might assume this is pericardial effusion from pericarditis. You might assume in a child this might be a tetralogy of Fallot, for example, if it takes on a boot-shaped appearance. A whole bunch of things, all right? We need the patient's history. You could say pericardial effusion, it's fine. Now, if you look at this one, you can immediately see a spot diagnosis. There's the presence of multiple pulmonary nodules that are large in appearance. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have multiple pulmonary nodules that are diffusely spread all across the lung fields, and they have a specific name because of their appearance: cannonball metastasis. And cannonball metastasis coming from malignancy, whether from the lung or not from the lung, but from other sites besides the lung, like colorectal cancer or cholangiocarcinoma, if you have a malignant molar pregnancy in women. All right, so there's cannonball metastasis, for example. If we look at case number 36, this is what we mentioned from before. This is a case of lung abscess because of the air fluid level, and we said why that is the case. So again, this patient will present with infection. Otherwise, everything is normal. And oftentimes, you might have more than one lung abscess. You have one large one, and you have another one right here as well. Look at the air fluid level here as well. All right, so the case of lung abscess. And if we look at this one, this is almost interesting. But if you notice, there is the presence of practically fibrosis. So everything looks normal here, relatively normal, although it's not as clear. I mean, it came from 98. But if we notice here, if we go up towards the right lung field, we can notice an area of opacification. So this area of opacification right at the apical surface, or practically at the apical right upper lobe, we can see an area of opacification. This area of opacification, it might more than likely suggest atelectasis. It must suggest a portion of the right upper lobe has been collapsed. And you can also see presence of ciliate sign. So there's a presence of ciliate sign with the right paratracheal border, as well with the ascending aorta. And oftentimes, you might see the horizontal fissure that's being visible, but it's not as visible here. So you might see this is a case of right upper lobe atelectasis. And why is there right upper lobe atelectasis? Maybe because there has been fibrosis with chronic inflammation and fibrotic damage to this area. It has caused this portion of the lung to be collapsed. And remember, when the lung is collapsed, there will be soft tissue density because there's no air. All right. So there's many differential diagnoses. We need history. This could be an old TB because of its position. An apical surface, this could be TB. This could be histoplasmosis. This could be, for example, aspergillosis. A whole bunch of things, all right? So we're going to say this is maybe a suspicious case of right upper lobe atelectasis due to chronic fibrosis or chronic inflammation in the area. Now, if we look at this one, Here we can see an abnormality, and the abnormality is in the device. So of course, he told you about the nasogastric tube to position. Obviously, the position of the nasogastric tube, it should go towards the esophagus. So in a chest x-ray, this nasogastric tube, which is basically a thin white line, it should go towards the middle. It should never deviate towards the right or the left. It should go towards the middle, all the way till you reach the cardiophrenic angle. You see this cardiophrenic angle? Yeah, you see it. So this line should go in a straight position until it meets the cardiophrenic angle. And then it goes towards the left, all right? So we'll go towards the left where it will meet the stomach, okay? You can clearly see the stomach. So it will meet the stomach and go deeper and deeper and deeper towards the stomach, 10 centimeters inside the stomach, all right? So this is the normal position, all right? The normal position of the nasogastric tube. A straight white line until it reaches the left cardiophrenic angle where it will go left and enter inside the stomach. But here we can see that the nasogastric tube, it had gone towards the middle and then it's deviated. It looks like that unfortunately the nasogastric tube, it went inside the trachea. So it went towards the carina where it will go towards the right mainstem bronchus, and this is bad because now this nasogastric tube, now it comes towards the right mainstem bronchus, and it will eventually reach the right lower lobe, and this can lead to complications. This can lead to right lower lobe and middle lobe atelectasis. It can lead to lung collapse, not pneumothorax, atelectasis, and that's another video for another time. But the abnormality is that there is improper emplacement of nasogastric tube placement. All right. Now let's look at case number 39. In case number 39, there is notching of the ribs, so it's not visible here. But if you take a zoom in of the same patient, you can see notching of the ribs. And notching of the ribs in this appearance might suggest aortic cortication. Maybe you see this in a patient with a history of Turner syndrome. Again, you need the patient's history to really look for these findings, and you also need a radiologist because he will look for these subtle findings. But this one suggests to you a notched ribs. You know, the ribs are notched in appearance. If you look at this one and you look at this one, you also look at this one. But again, these are incidental findings. Now, if we look at this one as well, again, it shows the same case where it shows notching in appearance. This one is visible, notching of the ribs. Again, it might suggest aortic cortication. So we have the same case.